Welcome to Struggling Residents Pathway to Remediation. This is a CME presentation by the American Association of Colleges of Podiatric Medicine's Council of Teaching Hospitals. Today's presenter is Dr. Johnny Alayon, who received his doctorate from the Pennsylvania College of Podiatric Medicine in Philadelphia. He is board certified by the American Board of Podiatric Foot and Ankle Surgery. He served his residency at the University of Texas Health Science Center at San Antonio. After completing residency, he worked at the Austin Diagnostic Clinic in Austin, Texas. Dr. Alayon then furthered his career by joining Mercy Medical Group in Sacramento, California. After 5 years with them, he took a 1-year sabbatical in Saudi Arabia, working at the International Medical Center. Wanting to return to academic medicine and work again with resident training, he joined the Audie Murphy Veterans Hospital and then transferred to the VA at the Puget Sound Veterans Hospital, where he served as Director of Medical Education and Residency Director. Dr. Alayon then moved to Ohio, where he joined the medical staff at the Ankle and Foot Care Centers for 2 years, including working with their fellowship program. Currently, he is at the VA Northeast Ohio Healthcare System at their Youngstown facility. He remains actively involved in clinical practice and resident education. Always dedicated to training residents and interested in academic medicine, he completed a course for medical educators in June 2022, Trained to Teach in Medicine, with the Harvard Medical School. Completing the course has helped him to become better versed in learners, classroom teaching, clinical and procedural teaching, technology and teaching, and the basic pedagogical theories in medical education.
But basically, like I mentioned before, it's the talk, or everybody has gone through different pathways of how they got to where they're at, whether the residency directors or faculty members. But one thing that we all have had some level of experience, whether you I apologize everyone for the issues that we're having. But basically, like I mentioned before, it's the talk, or everybody has gone through different pathways of how they got to where they're at, whether the residency directors or faculty members. But one thing that we all have had some level of experience, whether you've been doing this for a year or several years, you're always going to get struggling residents. The goal, of this talk of struggling residents, a pathway to remediation, basically is to develop a transparent process on how to address remediation. Also, hopefully guide you in improving your pathway for methods for remediation. We're basically, the talk is trying to assist programs in having a good model to address remediation. If we review what CPME 320 gives us on remediation methods and unsatisfactory performance, as you can read, I'm not going to read it to you, and I'm sure you've read it. It's very vague. It kind of gives you, that you have to complete it no later than 3 months beyond the normal length of the residency program. But it doesn't give you enough information on how you should develop your program. And one thing that I've learned when I became residency director in Seattle was that you're gonna get these issues, and you have to be very transparent and develop a nice model for remediation. So the objectives of our talk is, how do we identify the struggling residents? First, we need to identify those that may, are, or will need remediation. And how do we know? I think that's probably the biggest question. How do we know that a resident is struggling, especially early on in the process? If it's a professionalism issue, it's very apparent. But how do we know that a resident is struggling and not being able to meet the competencies or meet what we would like them, where that we would like them to be at in this process? The other objective is to develop a transparency in the process. I think it's key to develop something and have it in your residency manual. It is important for everyone that is involved to know what can cause remediation, what it will entail, and what are consequences if not completed. At times we are in the mindset of see no evil, hear no evil, speak no evil. It's real easy to go to the point that we don't want to deal with that. But unfortunately, we all have to deal with it. And we're not, we cannot just start sweeping things under the rug and say, oh, that didn't happen. As much as we don't want to cause conflict or deal with these issues, it can develop into a tumor and infect the program. It can cause individuals that may be considering the program not to want to come. So you want to be very open-minded, very transparent in the process. Everybody understands the process. Everybody knows from the very get-go of once they get into the residency of what potential complications can occur if you get into the remediation process. And lastly, once we know, and we all know that we're going to have residents that are going to have some kind of remediation issues, if it's from the informal to the formal, I think we need to develop supplemental education that we can deliver to these residents to bring them back to where we would like them to be in the program, whether it's something as simple as setting up a mentorship, having exams, having them have a self-reflection if it's a professionalism issue, so that we can address the issues that will arise. Because unfortunately, struggling residents and potential issues with remediation will come to your program, whether it's early on or later, but you will have more than likely a resident that you will have to go through this process. So what is the struggling resident? I think that's a huge question, and it can go in so many different ways. But I think what's important is they don't meet competencies. And have we developed these competencies for the rotations that they will be taking? Whether it's dietary rotations, whether it's surgical, clinical, or whether it's outside rotations in medicine, emergency medicine, plastics. Have you sat down with these rotations and developed competencies that the residents must meet? Is it something that it's an inadequate performance? Are they not performing well within surgical cases? Is it something that they're not performing to the level of their year of residency in clinic? So that's important to know. Unprofessionalism, are they having issues with, this can go as simple as just being appropriate. My residency director has always said that, you have to dress like a doctor to be a doctor. You have to act like a doctor to be a doctor. And basically pretty much telling us that you have to be professional. This is something that you take into account. You want to be as professional, not only to patients, but to colleagues, to ancillary staff. And then lastly, what requires intervention? What do we need to do? Is it, we have to understand that it's not just competencies and performance that we have to address, but we do have to address professionalism. And how do we address professionalism, and how do we intervene and develop a plan for intervention for this? So most residents struggle. That is something that we all will know, whether it's personal issues, whether it's competencies, whether it's academic, whether it's being able to deal with the new dilemma of having, a lot of these residents that you see, this is their first real job, unfortunately. Is it a work ethic issue? And for each of these residents is very different on how they're struggling. So there's a broad range of reasons that a residents will struggle. Identification for residents, we know that identifying the struggling resident is complicated. It's multifactorial. There's potentially could be inadequate data. We don't have enough data. Evaluations can be problematic. The last two are the ones that we can control. So we can develop evaluations that give us better data on residents. As time progresses within your program, as time progresses with you in their program, you will be able to kind of develop evaluations that will give you better data to determine where our residents struggle. And unfortunately, this will entail having a struggling resident, and you get enough data previously to understand that the resident is struggling and that you needed to intervene early enough? Or is it something that potentially you needed to have better evaluation process? So now this next several slides, I'm going to show the complexity of identifying these struggling residents and how we may be able to simplify it. And ultimately, it's still not easy. It's very difficult. I think it's probably the hardest part is the evaluation process. I know we all, at least when I was a residency director, and in speaking and giving these talks previously, this is probably the biggest problem. Is not that you haven't developed a good evaluation, is are you getting enough evaluations to make a good, educated process on being able to evaluate these residents moving forward within their rotations. So if we look at the CPME and competencies, these are just generalized. CPME gives competencies for rotations is a resident has to know a level of medical knowledge, patient care, professionalism, interpersonal and communication skills, system-based practice, and practice-based learning and improvement. So this is, from developing a new residency manual when I became residency director in CIA, this is probably the most difficult. It was vague. What do I put down into these rotations as I'm sending these residents to? What are they supposed to get out of these rotations? And how do we evaluate their success in these rotations? Obviously, we were going to give them a pass, fail. It's very difficult to develop grading system. So pass fail will be ultimately what we're going for. But how do we address competencies for rotations? One thing that I did and developed is just speaking to rotations that I'm sending the residents to, speaking to them and making sure that we agree upon what competencies we want the residents, the interns, to come out of these rotations, whether it's internal medicine, whether it's infectious disease, plastics, vascular surgery. I sat down with each rotation and made sure that we had developed the competencies for each rotation, and the residents understood the competencies that they needed to achieve to pass that rotation. Simplified, it's knowledge, clinical reasoning or application of knowledge, their attitude on the rotation, and effective. Do they have issues, burnout, mental health? These are all professional issues that we can do, but we want to make sure that we are addressing these as well. So data matrix, that is basically how we are going to get information for evaluation of resident. So evaluation can be defined as peer, supervisors, nurses, patients. I think one key that has always been beneficial is getting ancillary staff involved in evaluations, not always proceeding with just having attendings or faculty. It is important if a resident is doing an internal medicine rotation in a hospital-based setting, it is important to use that nurse as an evaluator. Excuse me. Sometimes that gives you more information than having faculty. Nurses tend to be around the residents more. They do definitely give you information on the professionalism and how well they work with others. You can always develop examinations like the OSCEs, which is our objective structured clinical examinations that we tend to use. We used it in our residency program, and we try to do a quarterly process. I think the hard part with this is having attendings or faculty involvement. Obviously, everybody's going to have a group of core faculty, and hopefully that core faculty will be able to be involved. When you're testing first-year students, you can always use your second and third-year residents, as well as second-year students, you can always use your third-year residents. But you need to develop exams, clinical exams, and this is a good way to kind of know where residents are throughout the process of their year in residency. So if it's a first-year resident, where should our first-year residents be 4 months into their rotation? And understand that there are going to be residents that are doing certain rotations that are not rotations that others are. So kind of develop your OSCE to kind of make it very generalized and be very helpful for everyone. Observations, bedside ER, OR simulations you can do as well. These are clinic-based or bedside-based observations for faculty. You should be able to see residents in clinic, sit back and evaluate them. There are programs that have videos that they do, and they get clearance from the patient as well as the resident, understanding that they may or are getting videoed so that you can go back and evaluate, discuss with residents the things that you saw, what you can improve on. And lastly is self-reflection. I think this is something that we don't use as much as we should. I think residents should have the opportunity to self-reflect on how their rotation went. They can kind of explain to you where they can improve on. It's important for residents to understand that being critical with their education far exceeds of others being critical, but it will improve their knowledge base as well as their improve their rotation satisfaction. If they can go back and look at, okay, how did I improve? Where do I need to continue to improve further down the road? This will also tell the residency director, the evaluators, where this resident is, where you can improve upon their learning process. I personally believe that evaluating residents comes down to two things, which is performance and trust. Trust is the same as professionalism. So performance is how they perform, whether it's a surgical, whether it's clinical, whether they can do well on exams. But trust is how comfortable you are with them. If you look at this graph, if you look at the far right, the high performance, high trust, those are the chief resident, the ones that perform very well as an attending, as a faculty, as a program director. You trust them with treating the patient well, knowing what they should be doing at all times. There is also that resident, if you look at the top left, high performance, low trust, that's the toxic leader, the one that performs well, but is not a good team member. It tends not to get along with his team, is out for themselves, and is not worried about improving others. The other one is the low performance, low trust. Those are the residents that you're looking to see. Is remediation, how early do you need to start remediation? Is it something that the low performance started fairly early on and then there became trust issues and then you had to develop some type of remediation program? So these are, definitely residents that you need to look into. The key to this is there's sometimes that you have that medium performance resident that has developed a high trust with everybody involved. They're good team members, they help, they get along with everybody. Those are the residents that you definitely need to continue to make sure that they're developing better performance and giving them as many opportunities to perform higher. But there's potential for informal remediation with those, just as well as, the high performance, low trust. There's some level of remediation with those and the trust issue or professionalism issues. So, what you want to do is, it's not only important to look at the competencies, but it's also important to look at the trust or professionalism issues with them. Are you guys still able to hear?
Yes, you break up every once in a while, but I've been able to follow, and so it's not ideal, but I think it's absolutely good enough.
I apologize. I'm not sure why I'm getting so much problems with my computer, but I'll continue on. So there are 7 deadly sins of unprofessionalism, and this is something that you have to be aware of. So it's not just important on what you do on the job that is important, but it's how you do it that is paramount. So not only should you have understand what you should be doing, but how it should be doing it. I think the key for this is bedside manner, understanding the responsibility of being able to present yourself professionally. So the 7 deadly sins is unpreparedness. You're paid to do a job, but you're not doing it. So definitely look at residents that are not doing what they're supposed to. They're not interested in what you're trying to teach. They're pretty much interested in anything that you're saying, anything that you're not saying. Disrespectfulness, they're not seeing the hierarchy within the program, the first year resident, second year resident, and moving up. They're very comfortable with lying, cheating, stealing, anything to improve their performance, so they're not being honest with you. They have a poor or failed communication. They're not speaking. They're on their smartphones more often than not. And lastly is just laziness. They're more ready for lunch than actually doing their job, ready to leave, as opposed to completing their job that they needed to do. I've had residents that midway into clinic, they're pretty much tuned out and ready to walk away. Definitely not something we want to see, but something that you definitely need to address. I think this is where we look at, from a residency director or faculty, is what change of behavior are we seeing with these residents that tend to lead them to struggling? Is there some level of distraction? Is it a family issue? Is it a personal issue? Is it some disinterest in where they're at? Are they having sleep deprivation? Does it look like they're just constantly tired? They're not sleeping as well as they should be? Is there a level of depression or other affective disorder? Have you noticed that they've been going out or doing drugs? And these are all questions. You have to have a good core of faculty. You have to have a really good core of senior residents that you're comfortable speaking with, and they're comfortable speaking with you. Are there health issues with the residents? Sometimes they're not comfortable talking to everybody, but hopefully they have found some kind of mentor or a coach that they can communicate this with. Is there a learning disability? Definitely something that you need to find out early on. Definitely communicate. And something that I learned as a residency director and getting residents is making sure that you communicate, prior to selecting residents. Hopefully you can communicate with their school and some kind of professor, and kind of give you an understanding on how they learn, how well they learn, and obviously any personal disorders that they may have. So once we've kind of determined who the struggling resident is, and what level of struggle they're having, whether it's a personal, is it a performance, is it a trust issue, is it a professionalism issue, how are we going to develop kind of intervention for this? There's intervention is as simple as informal. It proceeds to formal remediation, probation, suspension, and dismissal. Obviously, the last one is the most difficult, but the last three are the ones that you definitely have to develop a nice transparency process so the residents understand. There's never a question that you are seen to side with one person or another. That you're very transparent with how we deal with these. So informal, I think the biggest thing that you need to develop is a mentor or coaching program. Obviously, you need to have a system where attendings that have an interest, obviously, in speaking and spending time with residents, and developing a nice rapport, so that residents stay on course, that they have time. And that's always, I think, the hardest issue with developing a mentor coaching process is the time component. I think every residency director, every associate residency director, the biggest question that faculty always comes up to us or to you is, well, I don't have the time, or I'm not getting paid for that time. And as always, we hope that your facility or where the residency program is has already established that there is some administrative time for faculty, or at least to the core faculty, so that they're able to communicate with residents, have time in their schedule that they can bring residents in to have personal discussions, performance discussions, and have a nice communication. That's not always the case, and I wish it was, but that's not always the case. Hopefully then you have faculty and a core faculty that finds time to spend with residents, assist them in performance-based competencies, assist them in their daily life issues. So that's definitely something that that is going to be a headache for most. It's going to be that problem that exists, at least from speaking, it exists everywhere, having administrative time for the core faculty. There should be a residency leadership check-in where their chief residents are communicating with the junior residents. If you get to a point that you need to have an informal remediation, a mentor, program director, assistant program director should send out a letter of concern, develop an individual learning plan, and it's basically a pre-remediation plan. So you're basically giving these residents a chance to prevent themselves from getting into a remediation plan because of their performance or their professionalism. So like I mentioned before on the struggling residents and identifying them, you want to be able to identify them early enough so that you can pretty much do most of your remediation through the informal process. And that's the ideal situation you have. Once you develop, or have a remediation plan, you have to have learning plans. So you have to develop, well, where are we going to be able to, how are we going to be able to remediate these plans? If it's a performance-based issue, there are online learning centers. APMA has an online learning center that if it's an issue with certain rotations or podiatry itself, clinical, that they're not performing as well in a clinical setting or surgical setting, there are online learning centers. There's ePresent lectures that they can do that they can get tested on. You can do book reviews, literature reviews. Obviously, you can repeat rotations. Also, unfortunately, that's time consuming, and you have to make sure that the rotation requirements are met. There are professionalism curriculum that you should develop. Resources for this is behavioral health. Most facilities have effective communication courses that you can have residents go through. You can do resources for training support. Lastly, I think in all informal plans, you should be able to, or you should offer and make residents do and complete a self-reflection paper on why they got to this point, what they did to get themselves out of this point, what are they planning to do from here to the future for preventing them from re-entering in an informal remediation plan. I think you should also develop with the mentors is continue communications, whether it's monthly, quarterly, biannually, or yearly, that you're communicating with these residents, making sure that they don't fall back into the same trap. So formal remediation, this is where, definitely you need to have this set up within your residency manual and make sure that all residents have signed that they've read the manual, or at least know that they have the manual and sign off that they did receive the manual. This is important later on throughout this remediation because if you get to the point of dismissal, you don't want the residents to say, well, they didn't know. So you have to be very transparent. You have to be able to have all this written out. It's not easy, but it's definitely something that needs to be done. on the formal remediation, it's in your permanent record and it is reported. It involves a local GME office. My suggestion is go to your GME office and see if they have developed a remediation plan. And then you can kind of use their remediation. If you need to adjust it, you can. If not, you definitely need to make sure that it's put into the residency manual. You have to have a formal individualized learning plan. You definitely need a timeline for completion. Usually it's 3 to 6 months. And you have to have them understand the consequences of not completing the full remediation, whether it's moving on to probation or a non-probation kind of process. So individualized remediation plan, the components. You have to set a specific timeline for completion, like I said, 3 to 6 months. You have to choose a mentor for the individual remediation plan, whether it's the program director, associate program director, or other faculty member that has accepted the position. You have to schedule routine meetings, and this is where that administrative time comes in. Hopefully everybody is able to have some administrative time that their facility has developed for them. You have to consider behavioral health assessment and support because it is understandable that residents that have to go through this will have some kind of potential mental issues, whether it's being just distraught and having to go through this. It's not easy. Definitely knowing that this is going to be reported and can be in their permanent records. You have to set goals, obviously smart or smarter. They have to be specific. It has to be measurable. It has to be achievable. It has to be relevant for the reason they're getting remediated. It has to be time-bound, engaging, and reassessed periodically. Like I mentioned before, recommend self-reflection. I would put down that definitely you would have to do a self-reflection. List the consequences of not completing the individualized remediation plan. Document all meetings. As we mentioned with residents when we're doing clinics and surgery, document. Same with this. You have to document everything that you've done, document all meetings, make sure that everything is done appropriately, make sure that it's done based on your GME guidelines, make sure that it's completed exactly how you mentioned in your residency manual. And lastly, make the IRP or individualized remediation plan more supportive and less punitive. So you're basically making sure that it is promoting improvement as opposed to describing everything that they've done wrong. So this is a sample of an IRP. This is from the St. Louis University GME Toolkit. It is a great starter for individualized remediation plan. As you see, it gives you the kind of the resident name, PGY, start date, end date. It tells you the competencies or entrustable professional activities that everybody's moving to. It gives a specific goal, requirements of education, whether they have to review literature, lectures, or books. It gives specific, measurable, achievable, realistic, and timely goals, requirements, who's going to monitor, how it's going to be monitored, the specific requirements for GME. Lastly, and most importantly, is consequences for not completing it or consequences for relapse. So if they've completed it and they come back and the same problem occurs again, usually this is a professionalism problem, but it can be a performance problem. Where are you going to move on to? Is it something that go straight to probation, or is it something that they go to suspension? So these are all things that should be on the individualized remediation. So probation. Now we're moving on to probation, and outcomes on probation could lead to suspension. It's very detailed plan. frequent reassessment and check-in. So I would say at minimal, it's a weekly reassessment, weekly check-ins. You're definitely monitoring these residents fairly frequently, and mainly because if they fail this and do not improve, the next step is suspension or dismissal. So it's really important that you kind of be on these on a routine basis. And again, it's, you've set up who is going to be the mentor, which, whether it's a program director or associate, I would say more than likely it would be one of those two. I wouldn't use core faculty. I would use probably an associate program director or the program director once you get to the level of the probation. Lastly, then you're getting into suspension. They've not completed or successfully completed the IRP during the probation. Deficiency is deemed to be too severe for probation. So it's something that they've done, whether it's professional or whether it's performance, that probation and allowing them to continue to treat patients would be detrimental to patient safety or delivery of quality care. They are entitled to a hearing once they get to the suspension level, and we'll proceed to explain what a hearing entails. So an appeal and hearing process. So once you get to the level of suspension or dismissal, residents do have the rights to a hearing. There is a hearing notification process and the hearing process itself. The rights to a hearing, it's a lack of promotion. So you're not performing a PG-1 and a PG-2. A suspension over 30 days has a right to hearing, contract termination or dismissal. So the process is you give the resident a written notice, state specific grounds. It advises the resident the opportunity to meet with the director, department head, or designee, advises right to request a hearing. The resident has 14 days to notify that he is requesting a hearing. You have identified, directed the hearing to be by the designated institutional officer. So this is where you go to the GME. You would like to get a designated institutional officer outside of the program so that they're not biased at all, and they are able to do the hearing process completely without any bias from the program itself. The hearing process, the DIO shall convene a hearing process panel. It usually is informal, as opposed to evidence-based hearing. It has a resident and program director have the right to present information. The panel shall have the right to adopt, reject, or modify the decision of dismissal or suspension and make recommendations to the DIO. The DIO will make the final decision and notify the resident and program director in writing. DIO's decision shall be final. All this that I've presented to you needs to be in your residency manual. The residents need to know the process of where everything goes from informal to dismissal, to suspension to dismissal, and the process that goes for all that. So as I mentioned, this is not easy. It takes time. It's not fun. As human beings, we tend to avoid conflict, but as we know, allowing a resident to complete a program and not be recommended or remediated because you didn't have enough data or you didn't want to present this, didn't want to have the conflict of having, were concerned with retaliation, we're hoping somebody else would take care of it. It's tough. And ideally, every program should know what they need to do. This is kind of gives you a guideline of the things that you should develop and should have in your manual. You should develop in remediation. There's always concerns about our evaluations. I think that makes it real difficult, but if from the beginning, they understand what the competencies they have to meet for each rotation, how the rotations are going to be evaluating them. And it's not just them, but their senior residents may be evaluating them as well. Nurses may be evaluating that as well. I think it's important that the residents know that. It does cause a program reputation. I mean, if you're a program that has dismissed residents in the past, students will know. Some students may not want to go to that program. Some students may, but I think it's important to they understand, whether it's a student or a resident, that the process was handled appropriately, that there was no question of why the resident was dismissed or suspended. It's important that it's all down in writing. So conclusion is, system needs to be in place. I can't reiterate that more. You have to have it in your residency manual. You have to have a process in place. Hopefully this gives you a guideline or at least an outline on what you need to do. You have to address why there is a problem with the resident. How are you going to coordinate a plan to improve that residence, whether it's a performance-based issue, whether it's a professionalism issue. Make sure that the resident engages in self-reflection. I think self-reflection is important to prevent that resident to come back and have another issue and be remediated. Create the plan with clear goals and timelines. They understand what needs to be met, who they need to communicate, and lastly, document. This is by far the hardest part, but you don't want to fear retaliation because you didn't document appropriately. You don't want to have a resident have to be in your program because you did not document or have the appropriate paperwork to either suspend, dismiss, or go through the remediation process. So hopefully this lecture gives you a nice guideline or a pathway to improve your remediation plan. Maybe this gave you some ideas of adding certain things to remediation plan. Develop maybe some educational program, use some educational programs that are out there on the web, the internet, in other programs that are willing to assist you. But lastly, I think, you know, in my talks that I've given in the past with this, you know, one of the things that I notice is that as residency directors, as faculty, this is not something that we're always comfortable with speaking to other programs. And what I found out that everybody has these issues. Everybody has that struggling resident. Everybody has the issue of the residents that needs to be dismissed or suspended, how they dealt with it. Communication is key. Finding, you know, people that are willing to communicate and talk with, you know, discuss the problems that you may be having or you know, that are arising in your program, how they dealt with it in their program, what you need to do. These are all important things that we must consider. Thank you.